Right. Welcome back, everyone. Thank you very much for staying on time. Our next speaker is our keynote speaker. To introduce Dr. Qureshi, I take a moment. For those of you who may not know this, he is my mentor. I owe a lot of his work and training and our actual setup of the programs to his vision and his mission of training fellows and residents and making them good neurologists, good stroke neurologists, good neurointerventionalists, and good neurocritical care physician. This unique model of having a combined fellowship was his idea, and we've carried those ideas through over the years. For by way of introduction, also, Dr. Qureshi is the first neurologist who was trained in interventional neurology by a team of neurosurgeons and neuroradiologists at Buffalo. And he was the only neurologist who was trained formally in 1990s and was a pioneer in many ways of starting the field of interventional neurology. He was also one of the first neurocritical care fellows at Johns Hopkins University and was a pioneer in starting the Neurocritical Care Society as well as making the neurocritical care field a reality. As a stroke physician, he has done excellent work in organizing stroke societies, the stroke conferences, and taking stroke to a level where treatment options, acute treatment options became mainstream, hence changing the field of and face of neurology. So we owe a lot to him for a lot of forward-thinking work that he has done. He's also published extensively. He has written over 500 papers, peer-reviewed publications. He's one of the highest peer-reviewed publisher, scientific paper writer from neurology perspective. Actually, he is the highest. I think there are a couple of cardiologists who've probably written more papers than him, but other than that, he remains the highest publishing neurologist. He's written many books, and one of these books have been given today, signed by me, to all of the presenters, all of the residents and fellows on how to write a scientific manuscript. That is Dr. Qureshi's writing. He famously would go on a weekend, and to relax on the weekend, he would just write a paper, and every weekend we had a new paper. And you pretty much need that to write 500 papers that he has done over his career. He is still young and energetic and keep on breaking new grounds. At this time, he is working on a certification program for UCNS for interventional neurology. So without further ado, I'd like to invite Dr. Qureshi to give us a primer on how to write a scientific manuscript, how to be successful in furthering our academic careers and how to do research. I think it would be extremely helpful for the residents and fellows to learn and to actually even stay in touch with him. I'm sure he'll be happy to help you and guide you, just like he was a great mentor and guide for all of us that have trained with him. So please welcome Dr. Qureshi.
Okay, well, thank you very much for having me. It's always a pleasure anytime I'm doing anything with Jawad. I think Jawad is too humble. He's not telling us that he and I started this field together. We were the first interventional neurology program with a training program at University of Medicine and Dentistry of New Jersey. So it was a very exciting time. And times have definitely changed a lot. So what I do today is actually talk about scientific manuscript writing for medical journals. And the first question everybody must ask themselves is, why should you even publish? What is there in it for you or for others in publishing? And I think that sharing of medical knowledge is an essential component of responsibilities jointly shared by all physicians. And it is almost a mandate according to the profession that we have chosen. And I think that the prompt and widespread dissemination of medical knowledge derived from a variety of sources alert scientists and medical professionals to the potential of new areas of research and also facilitate training of new physicians and research. But I actually want to give an example where medical knowledge was not disseminated in a timely fashion and its consequences. All of you can see that picture down there, and you will all recognize that that's the Brooklyn Bridge. Now, one of the things that there's a medical aspect to the Brooklyn Bridge. When the Brooklyn Bridge was being formed, obviously the foundations of the bridge had to be done underwater. So they had to have people go underwater and actually set up those foundations. And when those people would come up, essentially a lot of them would develop vision loss, stroke, severe extremia or extremity ischemia, and nobody was understood what was going on. And Andrew Smith was actually the physician who was there at the Brooklyn Bridge who was treating these patients. And in 1873, he described 110 such cases, although he had no idea how to treat them. Even the chief engineer also lost his vision because of this diving under the water and coming back up again. However, ironically, a year before in France, they already knew what was going on. They also knew how to treat it. So Friedberg had already discovered that intravascular gas can actually be released because of rapid decompression. And the treatment was simple: put them back again, put them down again, and slowly bring them up. And that would actually move the gaseous or the nitrogen gas from a gaseous component back into the liquid component. But Friedberg did not publish his work, and therefore people at the Brooklyn Bridge construction had no idea what they were dealing with and how best to treat it. So I think that does actually tell you that there is an importance in sharing your observations in any format possible so that patients and humanity can benefit. Now, ironically, there is a lot of medical literature for sure. But if you look at the medical literature, almost 90% of the medical literature is actually published by only 10% of the medical professionals. So I think that it's suffice to say that most people do not publish. Now the question is, why do 90% of the people do not or choose not to publish? And I think there's two reasons for that. One is actually the effort that's involved in preparing a manuscript. We've had residents and medical students, fellows for many, many years. And it's always surprised me that for them actually taking overnight calls, taking 2 days straight on call has not bothered them as much as actually writing a scientific manuscript. So it is actually writing a scientific manuscript perhaps is even more cumbersome than actually taking call. And also misplaced expectations. So when people write manuscripts, one of the challenges they have, they don't really use an organized system or a template. They're just trying to take all the thoughts they have and trying to put it together in some organized fashion that they don't even have clarity on how to organize it. And the second thing is misplaced expectations. Every resident, fellow, medical student attempted to write a scientific manuscript, but their expectations are somewhat strange or somewhat disconnected. Everybody thinks they will submit a manuscript to the New England Journal of Medicine. Within 2 weeks, they will get a letter saying that we have a distinct pleasure to accept your manuscript for the New England Journal of Medicine. However, most likely, what they're going to be saying is that we regret to inform you, your manuscript did not achieve a priority high enough for publication in Stroke. Now, somehow, the reality is so discouraging that many people will not even attempt to resubmit that manuscript that they could have gotten accepted in another journal. So I think that we have to set our expectations right from the beginning so that we can continue on this path, which sometimes can be a tough path. Now, manuscripts is not a single entity. It's actually a heterogeneous group of entity. You have original research, which means research that hasn't been published before. Even journals may actually request you to sign a document saying that you have not published this research before. And you can have full-length manuscripts. You can actually have brief reports and research reports, which are actually smaller case series. And obviously, then you have case reports. Now, most residents, fellows, medical students actually want to write a case report. And ironically, case reports are the hardest to get accepted because it's very rare to find an unusual presentation of a common disease. And essentially, finding a new disease is even more uncommon. And in fact, your best chance really is to actually identify a new treatment procedure, particularly if you're actually in the endovascular or neurocritical care field. But again, case reports are probably the hardest to publish, and some journals don't even take case reports anymore. And then we have review articles, which actually are based on already published work. And it can be an overview. You're actually describing, and it's more of a quantitative analysis. You're actually describing various aspects of the disease. But most overviews are usually accepted from authorities in the field. So in somebody who's actually starting, may be limited and actually get an opportunity to write an overview of a particular topic. Systematic reviews are getting more popular because there is actually an organization on how the literature was identified, the keywords, the search engines, and how many articles were identified and how many excluded and included in the end. And then meta-analysis is truly a statistical process. It actually is using statistical methodology to take the effect of a particular intervention and combining the effect over various studies. Now, when we first started publishing 25 years ago, there's no such thing as a registration. Who wants to register something before even they were published it? But in today's world, most journals require you register your work. So there is the clinical trials gov, which actually has been, the US National Library of Medicine has actually set it up based or for the National Institutes of Health. And any clinical trial that you're pursuing must be registered there. And now even observational studies and registries must be registered there. For observational study, you also have an option. You can actually use the World Health Organization registry network, and you can register your study there as well. And even when you're writing reviews, now you have to register them as well. So there is this Prospero system, which is actually an international projected register of systematic reviews, and you have to register them there. So it's actually interesting that regardless of what you choose, you actually have to register that to actually add to the credibility of the work that you're trying to publish. And actually for clinical trials, the FDA recently penalized certain studies that actually were not registered, or the updates were not registered on the clinical trial gov. Now, for each type of study, there has been standardized algorithms that have been developed. So I think in the last 10 years, we've seen a lot of algorithms that are developed. You also have the consort statement that's about clinical trials. You have the PRISMA that for systematic reviews and meta-analysis. You have the MOOS that actually is for meta-analysis of observational studies and epidemiology. You have START, which is actually for diagnostic accuracy studies. You have STROB, which is actually for reporting observational studies in epidemiology. And now even for case reports, you have CARE, which is a consensus-based clinical case reporting guidelines development. So these are all documents that are in public access domain or public domain, and you should benefit from them because it does actually allow you to understand the standardization process for the publication that you're going to choose. Now, each publication starts with the title. And titles actually, obviously you want to big the message there, but you can't put the whole message in the title. It will be too long. So you actually have to choose the components of the message that you want to put in there. For example, here is a title that habitual sleep pattern and risk of stroke and coronary artery disease. So obviously, you have a study population of 7,844 adults. You have the variable of interest, which is sleep duration and daytime somnolence. And then you have a 10-year follow-up where you're actually ascertaining stroke and coronary artery disease. Obviously, you cannot put it all in title, so you have to choose. So you can choose adults, you can choose habitual sleep pattern to reflect the variable of interest, and you can actually put the primary endpoint, which is the risk of stroke and coronary artery disease. And that's why you can compile a title. Now, titles actually are not as simple. You can choose. For example, the title I showed you is a theme-based title. It really is talking about the study design and the question. Sometimes it can actually be a question-based title. For example, is intravenous TPA beneficial in patients with ischemic or infective endocarditis? So the title is actually a question. And sometimes it can be a finding-based title. The results are actually summarized in the title. For example, intravenous TPA is harmful in patients with infective endocarditis. So you've already summarized your finding in the title. For publication, I usually recommend a theme-based title. And for abstract for a scientific meeting, I actually recommend a finding-based title, because usually a person has to review thousands of abstracts and they don't have time to meticulously go over the content of the abstract. So the titles actually alert them to which abstract is more worthy of further consideration. Now, authorship, interestingly, is actually very important. Not just who you select as an author, but whoever you selected, you're using the right name, the right first name, the right middle initial, and the right last name. Because that's the only way somebody can retrieve their work. And even if you miss a middle initial in the name, it becomes harder to retrieve that publication. So for people starting, I would recommend choose the format that you want, the first name, the middle initial, and the last name. Encourage people to have a middle initial because it will make it easier to identify their work, and just use it consistently. And then who do you put, or whose name do you put on the publication? And we always think that putting more people on the publication, it would be potentially beneficial. Almost that concept that many journals now call as guest authorships. Essentially, you're just a guest. You did not contribute at all. But I think one has to understand the risk of putting somebody's name where they actually have not given the permission or not enthusiastic about, which is far more ominous in terms of disciplinary committees, as opposed to omitting a name of someone who actually really did not deserve to be in the author list to start with. Now the abstract. And abstracts are actually important because a lot of time, many people are just reading the abstract. And here is like some example of that abstract. And essentially you can see that abstract actually usually structured. There was a time that some journals actually used unstructured abstract. So everything was just one paragraph. But most journals have moved away and they actually want headings. So when you're writing an abstract, I actually recommend using this template: background, methods, results, and conclusion. And below that, you can actually see what you need to put in there. I mean, for the background, most important is, why are you doing this study? Is this an important question? The method actually talk about the design, the patient population, and obviously the analysis that you use. And then the results, obviously in an abstract, you can't put all the results in there. So you have to choose. What do you think is the most important message of your study, and only use those results in there? Basically, sometimes people put about the baseline characteristics, how many people. Main thing is, what is the primary result? What was your primary endpoint? And what was the quantitative estimate and comparison of the primary endpoint? And obviously, a conclusion, usually it has to be no more than 2 sentences. What is the summary? And then what are the implications? Are you implying that people should modify their practices? Are you implying that this question needs to be studied further? And then actually look at it, you can see the importance of a structured abstract. And essentially, I would recommend that you actually use these 4 subheadings to start with. Obviously, some journals may have a different set of subheadings and you may have to modify it. But if you have these 4 subheadings, it would be easier to take them into another structured abstract format. Now the introduction. Introduction actually can vary. Most of the time it's 1 paragraph, may actually be 2 paragraphs. Sometimes you have to introduce the topic. For example, in a journal that actually has broader audience, if you're writing something about stroke, you may have to introduce a little about ischemic stroke or the subtype of stroke. If you're submitting to the specialty journal, Obviously, many people will consider it insulting that you're trying to educate them about ischemic stroke. So it probably is not needed. The main thing in the study introduction, if you have to get one message, it's why is this study important? Why is it even necessary to do this study? Whether you actually chose a diagnostic study, interventional study, review, you can actually mention it, what you're doing. But the most important thing is why you're doing the study. And sometimes you may actually want to put the study question in the introduction. But it's actually an important thing, broader recognition of importance. We all think that the study we are doing is the most important study. But is anybody else who actually think that it's an important study to do? Sometimes in the guideline statement, they would actually mention that these are the research questions that need to be studied. Sometimes in other publications, they would mention that these are the research questions that need to be studied. I strongly encourage you to cite those articles, particularly if there's a guideline, because then the reader, your reviewer knows that this is a question that other people have thought was an important question to address. So that's why you're addressing that question. Now let's talk about methods. So you have that introduction that's pretty much mandatory in every scientific publication. Now the methods. Now method actually, if we don't choose the structured format, it would be hard for you to capture everything that's necessary for the methods. So there's 6 subheadings I recommend. Study design, some basic components about the study design, a prospective study, clinical trial, retrospective study, observational prospective registry. Patient population, who are these patients? They're humans, they are actually looking at laboratory subjects, you're looking at normal people and the volunteers. Study intervention, and study intervention has to be described in detail. So when we use, let's say if we're using the term endovascular treatment, that probably is not enough. We have to actually say what kind of endovascular treatments are permitted. What was the parameter of the, are you using a particular endpoint to use, or actually the intervention is directed to a particular endpoint? For example, 2 particular attempts or attempts until revascularization achieved. So that these things have to be specified. And also ancillary measures, because it seems like any intervention, the effect is modified depending on the ancillary care that they receive. So if somebody getting endovascular treatment, it's actually important to mention that what the systemic blood pressure parameters were, what the serum glucose parameters were, how long they were monitored in intensive care unit, what was the antithrombotic regimen used after the procedure, because all of them can modify the results of the intervention. And then data collection. I think that we just mentioned data was collected, but it's actually important to mention who was collecting the data. If it's an independent organization, a CRO, a person who actually is not involved in the conduct of the study, it's always more helpful that somebody's looking at it from an independent viewpoint. And definition of endpoints. Many times I've seen, we put an endpoint, let's say symptomatic intracerebral hemorrhage is an endpoint. But without the definition, what is meant by symptomatic? Just any neurological deterioration? Are we talking about a neurological deteriorations of 4 points or greater on the National Institute of Health stroke scale? Over what period of time? Within 24 hours, within 72 hours? And then the hemorrhage, are we actually taking any hemorrhage? Are we actually saying it has to be confluent hemorrhage that is exerting a mass effect? So all of those parameters actually have to be specified. And sometimes in retrospective studies, you may not be able to specify, but then you have to acknowledge that we use this particular information to determine that endpoint. And other thing is the completeness of follow-up. In a retrospective study, for example, there is no practical way, even with electronic medical record, that you can get information on everybody that was part of your data collection. So we actually have to mention what efforts were made, and in the end, what were actually the number that actually could not, the data collection was incomplete. And then statistical considerations. I think that in today's world, everybody knows some statistics. So every reviewer would have at least some level of statistical knowledge. So they have to put more emphasis on actually describing it. What is the statistical hypothesis? Saying endovascular treatment is greater than medical treatment or better than medical treatment is too vague. What do you mean in terms of better? Are we talking about reduction of death and disability as defined by a modified Rankin scale? And then reduction also has to be quantified. Are we saying that 10% or greater reduction, 5% or greater reduction? Because maybe 1% or greater reduction is not even valuable, but that would still meet the definition that endovascular treatment is better than medical treatment. So obviously the threshold or the magnitude that defines reduction also has to be specified. Now, even for retrospective studies, they're asking that you do sample size calculation. So you have to add sample size calculation even for retrospective studies. That why did your sample size consist only of 100 retrospectively collected patients? Why not 500? Why not 25? And obviously the method of analysis, whether your multivariate analysis, univariate analysis, all of that has to be specified. And even now the software you use, even if you're using Microsoft Excel, you have to actually mention the version of Microsoft Excel that you use in the statistical methods. Now we actually move to the results section. Obviously the results section is important because that is actually whatever you found, and that would actually dictate whatever your discussion would be. So I actually recommend the following subheadings. You can actually start your results with subheading. You can delete the subheadings after it's all compiled, but it would look more organized that way. Subject identification. Every journal now for clinical trials is requiring, you have to mention how many patients you screened. So let's say you included 20 patients, but you probably screened over 100 patients. So you have to mention how many people were screened and how or why they were excluded. Even in retrospective studies, you have to mention you screened 100 charts and only 25 people met the criteria, and the 95 or 75 people who did not meet the criteria, why they did not meet the criteria. So this is something we have to actually put in there, and we always omit that what was the denominator before we started. And obviously the study population. And what are the basic characteristics of a study population? Obviously you have to determine the gender distribution, the age distribution, and the clinical characteristic, the cardiovascular risk profile, because most of us are actually going to publish in the cardiovascular disease domain. And also sometimes people want clinical and physiological characteristics. For example, what was the median NIS stroke scale? What were the physiologic parameters like systemic blood pressure, serum glucose? So those are some of the things that we have to mention. Now, study intervention, you would actually say, we already talked about the study intervention in the method section. Why do you have to talk about it in the results section? Well, you may have actually contemplated a particular study intervention, but not everybody would have gotten that intervention. There's always a chance that some people did not require study intervention. Some people did not qualify. Some people pulled out and decided not to have the intervention. Some people crossed over, for example, from the medical group into the intervention group because they just didn't want to be in the medical group. So all of that has to be put in there, that how many people actually got study information or intervention. And again, how many people are compliant with the protocol that is specified? You may have gotten endovascular treatment. You may have received intravenous TPA, but instead of what was recommended, let's say you only got 0.8 milligram per kg. So how many people actually had non-compliant intervention, or they were not compliant with the intervention? Obviously has to be placed in there. And the onus actually becomes greater if you're actually looking at a longer term intervention. Even if you put people on antiplatelet agents and you actually specify 6 months of dual antiplatelet agent, a lot of people will not take it up to 6 months. A lot of people will be non-compliant. And the onus is on the investigators to make sure that that compliance or non-compliance is mentioned, so that actually the interpretation is easier. And again, the same applies for ancillary care. Some of these parameters may or may not have been upheld as specified in the method. So obviously you have to describe the endpoints. If you're describing modified Rankin scale, you have to describe the proportion of people who had a modified Rankin scale 0 to 2 or 0 to 3. A lot of journals actually want you to specify 95% confidence interval as well to provide the precision of estimate. And again, what do I mean by description of endpoint? In the current world, we have cumulative endpoints. So what is a cumulative or an aggregate endpoint? You can actually have, for example, let's say the SAMPRE study. The primary endpoint was any stroke or death within 1 month, or ipsilateral stroke to the side where the intervention was performed over the next 2 years. So any of these endpoints would have actually met the primary endpoint. But people actually want to know how many people actually had stroke within 1 month, how many people died within 1 month, and how many people had ipsilateral stroke over 2 years separately. And the classic example would be the CREST trial, where you have a primary endpoint that was 7% in each group, endarterectomy versus stent placement. But it's a cumulative endpoint. Any stroke, myocardial infarction, or death within 1 month, or ipsilateral stroke over the next 4 years. So if you compare the numbers, the rate is the same in stent group versus endarterectomy group. But actually break it down, the rate of myocardial infarction was higher in the group that got endarterectomy, and the rate of stroke within 1 month was higher in the group that got the stent placement, even though the total aggregate number is the same. But it's still important for people to know what the distribution was. So you have to describe the endpoints or the distribution or composition of the endpoints. And then usually the comparison, most times it's univariate comparison. A lot of people actually are doing multivariate comparison because of these readily available softwares. And then if you're doing multivariate comparison, make sure that you know what variables you've entered and why you've entered them. They have to be prognostically important variables. And the same is true for the secondary and ancillary measures. So let's say that modified Rankin scale was your primary endpoint, but there's a bunch of secondary endpoints: neurological improvement within 24 hours, neurological deterioration within 24 hours, symptomatic intracranial hemorrhages. So those are all secondary endpoints, and they actually have to be described as well. And if you're doing comparison, then you have to mention the comparison as well. And now subgroup analysis. Most clinical trials actually have to specify the subgroup they will analyze even before the trial is started. They have to use the existing data to define those subgroups, whether it's actually defined by age, 80 years or greater, less than 80, whether it's defined by the severity of different neurological deficits, NIS stroke scale of 10 or greater versus less than 10. And essentially, you have to define the comparison of endpoints in these subgroups. And a lot of people are actually using figures to describe the whole subgroup analysis to make sure that the results, the primary result, did not differ according to subgroups. So that is actually the methodology, and I strongly encourage you to use subheadings, because that way you can organize your results. Otherwise, it's hard to put all of the results in some organized manner, and the more disorganized you are, more likely the people reading will be disenchanted, and more likely that the message may be lost. So obviously, the discussion section. Many times I've wondered, do we even need a discussion section? If you actually have the results, you've already told people what you've found. Why do you need to discuss those findings? But I think that there is perhaps some value in the discussion section. You are actually saving the reader a considerable amount of effort by writing the discussion section. So the discussion section actually has 6 subheadings. Some journals will actually have a little different distribution of subheading. But again, I strongly encourage you to use subheadings for your discussion. The first paragraph, salient finding, just summarize some of the findings that you think are the most important finding. If your finding is that death or disability was reduced in a particular subgroup of patients, then that is your salient finding. Now, the second paragraph is how does it compare with other studies? Obviously, there have been other studies on the same topic. They may be smaller studies, they may be retrospective studies, but there have been other studies on the same topic. So how does it differ? Are your results exactly comparable to the other studies? Or are they different from the other studies? If they're actually different, or if there's concurrence or discrepancy, try to find the explanation. Sometimes smaller studies that don't have independent ascertainment, single center study, are more likely to be biased as compared to multi-center studies with independent ascertainment. And that's why the results may actually differ. It's always surprised me that, if you are self-ascertaining your endpoints versus if somebody independent is ascertaining your endpoint, even in the same group of patients, the results or the proportion of endpoints will be different. And actually, there have been studies on this topic showing that it can actually differ. And in endarterectomy studies, If you look at your self-ascertained complication, you will be describing a rate of 3 to 4%. If somebody else is looking at it, they will actually take the rate to 7% in the same group of patients. So I think that sometimes it's just who ascertained the endpoint, and whether the definition of endpoint were different may actually explain the difference between other studies. Now, explanation for the findings. Sometimes you have to put a mechanism. Many years ago, when it's almost like 25 years ago, we actually were doing experimental models of intracerebral hemorrhage, and we were trying to find perihematoma ischemia. Most of you probably even haven't heard of the term of perihematoma ischemia. But 25 years ago, that was the most important thing in intracerebral hemorrhage. The intracerebral hemorrhage by compression of surrounding microvessels were actually inducing a zone of ischemia, and therefore blood pressure cannot be reduced because you can only provoke further ischemia. Now, we actually did experimental models. We couldn't find any ischemia. So obviously we can say there is no ischemia, but could there be a potential reason why we are not fighting ischemia? And the reason was that most studies that actually described ischemia were simply inflating the balloon in the brain parenchyma. So you have a sharp interface between the balloon and the surrounding parenchyma. When you actually hemorrhage, it's not a sharp interface. In fact, the hemorrhage actually moves almost like a serpiginous finger-like projection into the parenchyma. So the parenchyma and hemorrhage are far more intermingled without a sharp interface. And we actually found references from pathological studies in the 50s and the 60s that actually supported that concept that there was no sharp interface. And that is why there could be no compression or a surrounding region of ischemia, because the sharp interface never existed. So that is actually a mechanistic description of why your findings are what they are. Sometimes the finding may simply be because the design of the study dictated it. Then is implications for findings. You have these findings, what does it really mean? Sometimes the implication may be practice-based. For example, one study we did, we found that intracerebral hemorrhage rate in patients who get intravenous thrombolysis when they have infective endocarditis are very high. So what the implications are that patients who have infective endocarditis, perhaps you need to be very cautious in giving them intravenous thrombolysis even when they're presenting with ischemic stroke. Sometimes it may be research-based, that perhaps a particular study, for example, let's say the experimental model of intracerebral hemorrhage, what is the research hypothesis or implication? The research implications are that perhaps we need to study the same phenomena in patients now. Do clinical studies in patients, where actually was done, that patients were studied using positron emission tomography, replicating the result that we had actually found in the experimental model. So sometimes the implication is a practice-based implication, sometimes it may actually be a research-based implication. And then data interpretation issue. We all think that our study is the greatest study that was ever done, and after that, there can be no further study. But unfortunately, that's never true. Every study, the most carefully designed studies, have limitations. And we have to mention those limitations. What do we think are the limitations of the study? Like, for example, we did the ATAC2 study, a prospectively designed study. Months and years were spent in the design of the study itself. So one would think that it would have no problem. But nonetheless, it still had design limitation. One, that the intensive treatment group actually was more intensive than we had initially anticipated. The blood pressure reduction was greater than what we had thought would be in the intensive systolic blood pressure reduction group. Second, a larger portion of good grade patients got included. We thought that there would be equal distribution of good grade and moderate grade severity intracerebral hemorrhage. But unfortunately, that was not the case. Most patients were good grade patients. In fact, 70% of the patients had a Glasgow Coma scale of 15. And that was not the intent of the study, but this nonetheless, when it all played out, that's how the distribution of the patients was. Sometimes there may be conduct limitation. The patient recruitment was suboptimal. Sometimes the treatment application was suboptimal. But nonetheless, we have to mention those design limitations, or I guess limitations when you actually are interpreting the data. But we also have to say why they're not fatal flaws. Despite the limitation, there is some valuable interpretation or some valuable interpretation or information in the study itself. And then obviously, we have to describe why we think this is not a fatal flaw and the study is still valuable. And obviously conclusion, some journals want a conclusion, some journal may not want a conclusion. Some journals want a conclusion that different than the conclusion of your abstract. But conclusions are again similar to the format in the abstract. Summarize what your main findings are, summarize what the implications of these findings are. Now, one of the things that, in design or discussion is the question about interpretation. For example, older people have worse outcomes. That is actually a statement. Older patients with ischemic stroke have worse outcome. It's a recognition. But when you actually start saying that because age actually is the important determinant of outcome, we have to be a little bit more cautious. Could it truly be a cause-effect relationship? Or it could be a simultaneous effect relationship. For example, people who are older are more likely to have strokes. So people who are more older to have more severe stroke. So age did not contribute to the outcome, just other factors contributed. And again, like a bystander relationship. And this is a classic issue when patients with patent foramen ovale have ischemic stroke. Patent foramen ovale is so common. Patent foramen ovale have nothing to do with ischemic stroke. Just because it's a common entity, it was seen in patients with ischemic stroke. And sometimes there may be effect of various relationships. But nonetheless, if you're going to define something as cause-effect relationship, you have to test an intervention to modify the cause. And if it modifies the effect, only then you can say it's a cause-effect relationship. And then essentially, you may have to do further tests to apply the intervention and monitor the results of the intervention. So I think I just want to stress out that just because two things are found together in an observational study, don't actually directly or assume that there is a cause-effect relationship. It may just be a bystander relationship, or maybe both things are actually being caused by a common etiology, and that's not a cause-effect relationship. They're both consequences of a common etiology. And I think that, if you look at discussions, the two most important things that are actually considered fatal flaws in discussion: drawing conclusions that are not supported by the results. Your result may have shown something else, and then, for example, you showed intravenous TPA was beneficial in patients who were treated within 3 hours, but your conclusions are intravenous TPA is beneficial in patients with ischemic stroke. That is actually not the appropriate conclusion because the results were on a very selected group of patients. And claiming the impact of results to be greater than what can be justified after considering the various limitations of the study. You cannot tell people based on a retrospective study that they should modify their practices. Something is no longer applicable anymore because a retrospective study has its bias. It is actually more like a hypothesis generating conclusion rather than a practice-wise modifying conclusion. So I think these are two important things to know when you're actually writing a discussion. Don't overdo it, both in terms of saying what you're saying, and don't overdo it in some of the recommendations based on the study. And obviously you have to make tables. Almost all studies need tables. But I'm actually always surprised that the format of table is so suboptimal when people are actually drawing the table. The table actually has to have a proper format. You have to have a title. Many people don't even put a title on the table. But as you have your number, table 1, table 1A, table 1B, whatever that is. And then you have to actually have a content description. What are the rows that are standing for? What are the columns that are standing for? And if you're using any abbreviation or symbol, you have to describe them on the below or the bottom of the table. And the same actually goes for figures. Figures actually, I'm always surprised that why people don't put a legend or a title for the figure. Why people don't describe the abbreviation that are used in the figure. Because we have to put that in there. So anybody who's actually looking at the figure who doesn't have the background that you have should at least be knowing at what he's actually looking at. And a lot of time people actually highlight the findings in the figure as well. So when you look at the figure and you read the title below, you're familiar with what to interpret or what to actually take out of that figure. Now the word figure is very broadly defined. Unlike tables, where it's a pretty homogeneous entity, figures are a whole heterogeneous group of things. It can be graphs. It can be plots. It can actually be pictures. It can be pictures of imaging, photographs of imaging, sometimes photographs of individuals. It can actually be photographs of histomorphology or histology. So obviously there is a whole set of figures that go in there, and you have to actually describe it. You have to actually mention the details about the figure. If you actually have a figure of a person, you have to mention you took it by permission of the person, and you have removed the de-ident or identifying feature. If it's actually a figure of histology, you actually have to mention the magnification that was used, whether it was 200 magnification, 100 magnification, special stains that were used. And similarly, sometimes a lot of journals actually require a figure for patient flow. You say, reviewed 100 charts, 75 of them met the criteria, 25 of them actually met the patient that you were actually looking for, 20 of them actually had complete data. So they're actually asking you to make a figure. So they don't have to read and understand. They can just look at the figure and understand how the flow of the patients was. And again, same is actually for modeling and comparisons. This used of the time need advanced softwares. And if you're using advanced software, the software will actually plot the figure. And also, I strongly recommend that when you're writing the legends, increase the font of the legend so people can actually read it. If the font of the legends or even sometimes table is so small, people cannot read what those legends or get the axis, the units of the axis, and actually the values of the axis. So I think that there is almost like a beautification process for figures as well. So when you make those figures, step back and look at it and see how can enhance the quality of the figure. So now you have your manuscript. You actually submit the manuscript. What is the most likely of these 5 outcomes? We are not in person because I usually ask people to have a show of hands. What do you think? You've submitted a manuscript. What is the most likely or the greater likelihood? What is of these 5 or 6 categories the response will be? I know for the manuscript I submit, the most likely response is number 1, reject. So if you get the same response, you're the same category as I am. If you get anything else, you're better than I am. So that's good to know. So reject is the category where you can get a response, and that is pretty much the end for that particular journal, but it's not the end for your manuscript. You can always get a manuscript submitted to another journal and get accepted. In my personal experience, it's usually 2 or 3 submissions to different journals before the manuscript is accepted. So don't have a heartbreak over it. Just simply say if there's anything valuable to be fixed and just resubmit it to another journal. Rejections are many times. Sometimes it's the quality of the study. Sometimes it may be the priority of the journal. The journal just doesn't like that topic. So essentially, don't actually, take a rejection hard. Sleep over it, get back the next day, and just resubmit the manuscript. Sometimes it's reject and resubmit, which to me means resubmit. Essentially, fix it and resubmit. Major revision, minor revision, also obviously is a much better chance that the journal actually would accept your manuscript. Except with minor changes, again, that's a very good omen. Except without any changes. And I actually have like 790 publications. There's only 2 publications in there that were accepted without any change. Only 2. So if you learn this is going to be your satisfactory endpoint, modify your expectations. Now it's very, very rare that you would actually get a letter saying they don't want any changes, they want to accept the manuscript as it is. So look at the following outcomes and simply titrate your expectation so that it doesn't become an end all or a be all statement for you when you get the recommendation. So when the reviewer's response comes, you have to write a response to the reviewer. You have to address each point step by step. And in the book that you have, I've given some examples how to respond to the reviewer. When I've seen, I've been a reviewer myself for many journals, and I've seen responses that kind of vary from, the reviewer made an excellent suggestion to the reviewer has nothing valuable to say. And trust me, to the reviewer, this is a special offense if you say the word, the reviewer has nothing valuable to say. You can be sure that reviewer is going to give the lowest priority ever. So it's better to acknowledge what reviewer is saying and take it for face value and say that there is something valuable that actually needs to be addressed. And a lot of time, they may actually have recommendations that, usually take about the objectives. Mainly they're trying to get a sense, is this a valuable thing to do or not? And a lot of people who are familiar with the literature can justify it's a valuable thing to do or not. Methods used. Now, in objective, there's always that question about fatal flaw. The reviewer may just think that we already know the answer to that. And that actually happens in certain opinionated journals where reviewers are just, I like this question, I don't like this question, I'm done. And similarly with the methods. Methods can also have fatal flaws. For example, if you're using to determine an endpoint using an estimated methodology that's highly flawed, then it's a fatal flaw. And regardless of what you do, the reviewer has already decided or what you have done is not going to get accepted. But doesn't mean that other journal may not accept it. Other journal may still be accepting of your methodology. And the accuracy of the results. If there is any suspicion that your results are not accurate, that is an automatic rejection. This is a fatal flaw. It cannot be redeemed. So now you will say, how does the reviewer know whether I'm presenting the result accurately or not? And the answer is something very simple. For example, you say there's 50 women and 50 men in the study, but the total number of patients is 105. The reviewer just simply added it up and said, there's something really wrong with what you're doing. How can 105 patients be only 50 men and 50 women? Unless you ever said that in 5 you couldn't determine the gender. So usually they're using simple things to determine whether results are accurate or not. They don't have the data sheet. They don't have the Excel form. They don't have the software in front of them to run the analysis. Sometimes they can actually judge by the confidence interval. If your sample size is small and your confidence are very tight, they know it cannot be accurate. So they're using indirect measures to determine whether the results are accurate or not. And you can read your own result before you submit to make that ascertainment yourself. So I strongly encourage people when they submit, look at the results and step back. They're actually making sense or not. And similarly, the interpretation. The interpretation of the result is usually very rarely flawed. When I told you the limitations in the interpretation, the reviewer may simply identify the same issues and ask you to reinterpret your result. And most of them, that means a revision. It will be very rare that the reviewer will say the interpretation is flawed and this has to be a rejection. But the biggest reason where there is no coming back is if there is any question about the accuracy of the results. If there's any question the data was not run accurately, that is a fatal flaw and there is no coming back. So when you write the response to the reviewer, the best things are things you can fix. The reviewer has actually asked you to do something and you can do the things. If the reviewer has said, analyze it this way, you can simply redo the analysis. That is the simplest fix and everybody is going to end up happy. But sometimes it's a challenge. You cannot do the required action item. For example, the reviewer says, collect this data. You can't go back and collect that data. That data was never collected. There's no way you can find that data. So now you have a challenge. You have to actually explain. So you can actually go back to the literature and say that this is what we know from the literature. And therefore we think that, whatever we did is still accurate. And another solution is that you can simply say, well, yes, we can't do this, but it's a limitation and we will acknowledge it. We will acknowledge it in the discussion section that we did not collect data on this particular item or this data was not available in the chart, and we acknowledge it. But we still think this is valuable information despite the fact that we couldn't do what you were asking us to do. And a lot of time that may be enough. But everything the reviewer said, there has to be an answer and something done in the manuscript to respond. When you write a response to the letter, this is not a letter to the reviewer. This is actually modification in the manuscript based on the suggestion of the reviewer. So always, every comment they have, try to do something in the manuscript that actually the reviewer actually to answer the reviewer's comment. And then again, sometimes, you just can't address the comment. Just don't have the data. Just don't have the resources to address it. Sometimes the patient consent may not allow it. And then you simply have to acknowledge this as a limitation. But these are actually some of the things for response to the reviewer. And you have to organize it in a way so when the reviewer reads it, He's happy you've done something valuable. You've listened to him. Obviously, anytime you give somebody a comment or advice and they don't listen, you're not going to be happy about it. The reviewers are the same. They're giving you advice, and if you're not going to listen to it, they're not going to be happy, and they're going to make sure the manuscript has the lowest priority in their mind. So I'm actually going to conclude here. I didn't want it to be too long because I want to actually have a time for discourse and discussion. But I wanted to cover to make manuscripts structured and organized. And these subheadings will allow you to get to this point. If you don't have the organization, you will struggle with writing the manuscript. You will struggle with putting all the information you have in an organized manner. And a lot of times you may actually omit valuable information that you may come to regret later. So here I'm going to conclude here with the following. Why should we publish? And many of you are in the beginning part of your career, and you're probably asking this question yourself. Should I actually publish? Why should I publish? Should I go through endure through the challenge of publication? If I can actually accept, even at this stage, after 30 years of publication, a rejection rate of 50%, I think that perhaps you also need to tailor your expectations. That this is this is what the expectation is. This is what the reality. And I'm going to get through this reality. I'm going to move forward with this reality. This reality is not going to hold me back. And manuscript writing also, one thing I did not mention, but I probably should have. Tailor your expectations. In general, any achievement in life, it's a set of stairs. It's not a big jump. And every time you write a manuscript, your first manuscript getting accepted in the New England Journal of Medicine, this is a very inappropriate expectation. This is an expectation that's doomed to failure. You can start with a much smaller journal and work your way up. And you have more publications. You'll be in a better position to eventually publish in New England Journal of Medicine or Lancet or another high impact journal. But don't actually expect the first publication will be in the New England Journal of Medicine or Lancet. But I think there's a broader view of why we should publish. I think that it actually plays into our own existence. It actually is an important part of our own existence because it's allowing you to express yourself, allowing you to have an opinion that other people can listen to and actually benefit from that opinion and to learn from what exists. In residency, I really very rarely studied textbooks, but I did write manuscripts. So every time I was writing manuscript, I was reading all that was already published. So my knowledge is very up to date on what was already known about the field before writing a manuscript. So in some ways, writing a manuscript is also a very good opportunity to know what's already out there and keeping your knowledge up to date. Obviously, it's to share with others. We always share things with others. Sometimes we share our resources, sometimes our finances, our wealth, but we also have to share our knowledge. And I think that's the most important thing, to share knowledge. I think that one of the saying is that who giveth life to knowledge died not. So I think sharing knowledge with other individuals is a very important component of who we are. And I think there is a bigger contribution to humanity that we are making every time we're publishing scientific manuscripts. So I hope that this would motivate you and guide you to perform or write scientific manuscripts and publish scientific manuscripts. Well, thank you very much.
Thank you very much, Dr. Qureshi, for this excellent presentation. I'll open it up to questions. People on Zoom can type in your questions. Dr. Qureshi, I wanted to congratulate you. I didn't know the latest count has exceeded 750 now. You're 800. So I apologize for saying 500 plus because
No, no.
it's all relative. Congratulations for doing that. You've been an editor of a very successful journal for a long time, and which is an index journal. From that experience of being an editor, how do you usually manage the manuscripts? Do you Can you just give a little
Sure.
bit of a personal view of how you judge a manuscript when it comes to you?
I think that's an excellent question. My name is, so I've been an associate editor for the Journal of Neuroimaging. I've been on the editorial board for Stroke, and also been editor-in-chief for Journal of Vascular and Interventional Neurology. And then a more recent journal, Healthcare Research Journal, because of all the COVID-19 research, we had to find something else. So now, when you are a journal editor and you receive a manuscript, the first thing obviously is that you just read through the topic and decide, is this an important question or not? And a lot of people have good questions. So obviously people who are writing manuscripts are qualified individuals, so they already have enough knowledge to determine what the good question is. So the next question, and I will tell you this, the most frustrating thing as a journal editor is the quality of write-up. A lot of people have valuable information in there, but the quality of write-up is so suboptimal that one has to say, well, if you have to rewrite the whole article, is it really worth all the time and the effort? So I think that, if we can put more effort, or anybody submitting a journal can put more effort on improving the quality of write-up. And actually, I'm so surprised, and sometimes people don't even use spell checks. And like so many softwares today, they would automatically identify these formatting issues. So I think that we don't have to be a major in English or a PhD in English. The softwares actually already do that. And also medical scientific writing is a little different than English writing. So I think that there is a certain unique aspect. But the only way to know that is read more articles. That's the only way you can learn what scientific writing is and how it differs from English writing. And then, benefit from all the softwares out there. And I think that's an important issue that, with manuscripts, if the editors feel that it's just going to be too much of an effort, then sometimes even if the information is valuable, they've kind of caught in a crossroad whether the whole effort that would be required to bring it to that standard may really be worth it or not. In our channel, we made an effort. A lot of time we tried to do extensive editing if the content is of value. And a lot of time, people actually, I think that at least some of the people who have done that have appreciated that. And I hope that we learn from it. So every time something is being edited, and even, you publish somewhere, we look at the galley proof and look at the edits that I guess the proofreader or the proof editor has made and try to learn from it. So don't actually just simply take all the changes and just click the button accept. Actually read through each change so you're learning from the changes that we've made. So next time you don't even have to have those changes somebody else making it. You can do it yourself. And everybody starts at a lower level. Nobody was born with the skill. I think that the first time I wrote a manuscript, it took me like 3 months of just editing it and being embarrassed in front of all the faculty I showed it to. I think that the first time I showed it to a faculty at Emory University, the advice I got was, maybe you need to take English classes. I still remember, and he's a very dear mentor, and we wrote many manuscripts down the line. First time I looked at manuscript, he said, my English is either A or B, but your English is a D. So I think that, but don't let it keep down. You can actually get to an A from that standpoint. So I think those would be some of the advice.
That's also a very good point, that looking at what the journal wants may help you a lot, like looking at the previous journals and looking at what topics excite them or what topics interest them more would make sure that you're sending it to the right journal that the content is needed for. Is that something that you look at very closely?
You mean about the impact?
Like the actual content of the article is along the lines of what you want for your journal.
Yeah, I think with the content, obviously the main thing is the theme of the journal, so it has to be consistent with the theme. And I think that's why we created the Healthcare Research Journal, because a lot of things that were coming in were good information, good science, but were not necessarily what a journal of vascular intervention neurology would encompass. So sometimes things can actually be outside the theme of what the journal is expected to cover. And the problem is that the PubMed actually monitors that. So every time there's serial monitoring, they will actually look at the manuscript and make sure it's consistent with stated objective of the journal. I think the journals are under increasing scrutiny now because there is this new term that has been coined. It's called the predatory journal. And it has been coined by the journal that should be classified as predatory journal. So basically, these are journals that actually are taking money for publishing your work. And Obviously, it's almost like a profiteering. There's journals that are actually charging $3,000 for each publication. So if you're a rich person, that's a big challenge. But actually, if you look at which journals are actually charging, a lot of the Lancet journals are charging that. Like journals who are charging just to actually review your manuscript. So I think that this is becoming a very business model, which I think is probably not fair to the scientific community. I mean, obviously, rich people are not the only people who have good scientific information. So I think that perhaps at some point the system should autocorrect itself.
Thank you very much again, Dr. Qureshi. There are no more questions that I see. Dr. Qureshi, it was an excellent overview, very nicely broken down into each section. I think all the trainees, the fellows, the junior faculty, all would benefit a lot from this lecture. Thank you very much again. And we have distributed your book to all the presenters who had presented. And we do have a little token of appreciation for you.
Oh, wow.
I wish I could hand this over as our token of appreciation. This plaque says that you're a keynote speaker at the 18th Annual Zapula Day. And thank you very much again. We will mail this to you, your plaque. And thank you again for coming. I know that you had a busy day. You were in a case just before you came on Zoom. So thank you for making the time and giving us this valuable information.
Yeah, I want to introduce Bay, poor person, our student who actually put all the publication, all the slides together. So, and I think one thing I wanted to mention, I'm actually very interested in conducting seminars. So basically, have a group of trainees, and one person has written a manuscript, and we all go over the manuscript together. And because once you actually have a actual content, and you are actually going over the content with everybody else, and it has an interactive session, and I think that is even more helpful. So I think as these restrictions on COVID-19 are becoming less, perhaps something that we should consider doing together.
Oh, that'll be amazing. That'll be awesome. Would you be willing to do that? Like, we send you the manuscript first, you review it, and then critically discuss the manuscript?
Well, thank you very much.